All right, welcome everybody. Today we have Holly Landerman, who is a stroke coordinator, here to talk a little bit with us because it is Stroke Awareness Month. So providing some good information about her career and how to detect signs of a stroke. So without further ado, I'll hand it over to you, Holly.
All right, sounds good. I'm just going to start sharing my screen here. Let me see if I can figure out how to get to my okay, I gotta move this guy here. Let me see. All right. I think I saw all blue pop up on your faces. So you should be able to see my PowerPoint now. And you can hear me, right? Okay. So just a little background here. So I'll introduce myself. I am Holly Landerman, a stroke coordinator at All Saints in Racine here. All Saints is a Joint Commission certified primary stroke center. I've been involved with our stroke program since 2013 when we became stroke certified. My background is a nurse in the intensive care unit here at All Saints. I worked in the intensive care unit for 25 years. And then I've been the stroke coordinator also for the last several years. So just a couple objectives on the screen there for you. Some things that we really want to be impactful. But first I am going to show you a little video here. Let me just...
Do you have to share with the sound?
Sorry, just trying to get out of the screen here. Okay. There we go. Okay, so you should see on the screen now what is stroke, right? So basically that's what we're here to define today. What organ of the body does stroke affect? I'll give you a clue. There you go, it affects our brain. So according to new research from the American Heart Association just released recently, almost 30% of adults younger than 45 don't know the 5 most common signs of stroke. At the same time, stroke is on an increased rise in that age group. Each year, about 10 to 15% of the nearly 800,000 people in the US that have a stroke are between the ages of 18 and 45. And despite the decline in general population, strokes have increased by more than 40% among the younger adults in the past several decades. And we'll kind of define later on in our presentation of why that is occurring. And my goal right now is for all of you to be aware of what stroke symptoms are through this presentation, and most importantly, that stroke is a medical emergency and that it takes all of us as a community to improve the care of our patients out in the community by first recognizing what a stroke is. So let's go over some anatomy. So stroke is a vascular event, meaning that it affects our blood vessels within our neck and that lead to our brain. So the brain is supplied by 2 arteries, the carotid artery and the vertebral arteries. Those are the only 2 arteries that go up to the brain, and then it further divides. So the carotid artery is feeding the anterior portion of our brain, which is the frontal part of our brain. So this front part, which is actually the largest portion. And then the vertebral arteries are feeding this back portion of the brain, what we call posterior circulation. So the carotid artery comes right off the aortic arch, which is connected to your heart. So your carotid, you got a right side arteries and left sided arteries, not only the carotids, but also the vertebrals. And the vertebral artery actually comes off of the subclavian artery. So just to kind of give you a little diagram of how this is all leading blood flow to our brain. And then we further look at each lobe of the brain. The brain's divided into many lobes, and each lobe controls certain aspects of function. Basically, I explain it that the brain is like the engine of the car. It controls everything, right? So not only our vision, but our balance and coordination. Our cerebellum is where we get all of our coordination from, to our memory, to our language, our motor skills, our speech, all of those entities. And then depending on where a stroke is occurring will depend on what symptoms a patient may have or a person may have. So 2 types of strokes. So nationally, 87% are ischemic strokes. This is the most common. And this occurs when a blockage occurs in one of the arteries going in the neck into the brain or one of the smaller arteries in our brain. So as we age, plaque and cholesterol can build up in our arteries, and this is the same reason a heart attack happens. So that plaque and cholesterol is that yellow portion. It kind of gets like the hard, like the plaque on our teeth. And then it can break up and a clot can start to form there and block the blood flow, causing a stroke in that area where tissue is dying. The second type of stroke, 13%, are hemorrhagic strokes, meaning that a rupture occurs of a blood vessel. There's 2 subclasses of the hemorrhagic strokes. So intracerebral hemorrhage, where a blood vessel bursts inside the brain, and that is typically caused from uncontrolled high blood pressure. And then the secondary stroke is a subarachnoid hemorrhage, and the majority of those are caused by an aneurysm rupture. And we'll talk a little bit further about that in just shortly here. With the hemorrhagic stroke, those patients can typically develop a sudden, severe, most horrific headache ever. And that might be their first symptom of it. And then they may develop those other typical stroke symptoms that we'll talk further about. So I'm just going to start off with a patient here. This is a real patient, a 71-year-old female. She developed numbness and loss of sensation in her left leg. So she couldn't sense anything in her legs. She had no feeling. She was in the basement at the time when it happened. She was getting out some fall decorations. And she actually had to crawl up the basement stairs because she felt like she was going to fall because she couldn't feel her leg. And she called 911. And actually, when I interviewed her, when I spoke with her after the fact, she said that she was actually looking, she must have had a mirror or a window nearby, that she was looking in the mirror to see if her face was drooping or any other signs. But all she had was that kind of numbness and that heaviness of that leg. After she arrived, she was actually unable to even lift that leg off the bed. So she had some weakness in that leg. So how do we know what type of stroke a patient might be having? So our first thing is to do a CAT scan of a patient's brain and head. So basically the patient lays on this table here and this machine scans them. It's like a little donut. It's not like an MRI. It's a little different. It's open-ended. And then the table just moves slightly in and out, and it's basically looking for the picture in the anatomy of the brain. And this is what this patient's CT showed. So I'm here. I don't know if there's a little laser. There we go. So you can see this white portion right here. It's identifying that that is a hemorrhage. The initial CAT scan is only going to pick up the bleeding type of stroke, this type of CAT scan. And that's going to be immediate, that it's going to show that hemorrhaging that's occurring. So many times patients or families may describe the person's stroke symptoms by these comments. So my right side feels dead, my leg feels heavy, my vision is blurry and I'm just so dizzy I can't even walk. One lady explained it, she just kept dropping the coffee cup. She couldn't hold a coffee cup. Families may describe it as that the person seems suddenly confused. And that is because they can't express themselves properly because it's affecting their speech center. We're actually going to go through each of the stroke symptoms. So you may have heard of the FAST acronym before that the American Heart and American Stroke Association has utilized for a long time. But we've added the word BE to FAST. So it's BFAST. Wisconsin is actually very fortunate. We are part of the Coverdell Stroke Program. Paul Coverdell was a senator in Georgia that died on the Senate floor of a hemorrhagic stroke. And the Senate determined that we needed to improve stroke care. So they developed this grant program, which developed the Coverdell Stroke Program. And Wisconsin, there's 9 states involved in this program, and Wisconsin is one of them. And the goal of the program is to improve stroke care throughout the state. So not only, patients down here in Racine, but patients way up in, those further northern counties will have the same stroke care and the recognition of stroke. So the Coverdell Stroke Program developed this, this little lady's name is Bella, and she actually has all the stroke symptoms on her. So those that can't read, children or, potentially others that may not be able to read English or read at all, can look at her and see what stroke symptoms might be. It's also the recognition not only of the anterior portion of the brain stroke symptoms, but also the posterior, the back part of the brain symptoms. And remember, stroke symptoms are going to be sudden in onset. It's not something that someone's had for months and months and months. It's going to be suddenly they're going to have these. So we're kind of going to just go through each one.
Holly, sorry to interrupt, but we can't see the image that you're trying to demonstrate. I don't know if it's on the same slide as the 71-year-old female or if it's a different slide, but we can't see the image.
Okay, let me. So you see the 71-year-old female now, right?
We see like the whole left side that shows the machine and the bullet points. Oh, there we go. Got it.
Okay, and then now the other screen.
Yep.
Now you should see the BFAST.
Yep.
Okay, perfect. Sorry, thank you for letting me know. Technical difficulties, Okay, so we're going to go through each of the BFAST symptoms because each letter stands for a potential stroke symptom. And another thing I think that's real important is that a patient having a stroke may not have each one of these symptoms. They may only have one. Patients that have multiple symptoms, that's a pretty large blood vessel that's being affected in a larger stroke. So here we go. B stands for balance. So the person may develop a sudden onset of loss of balance or coordination. They may feel like they can't even walk straight. They may feel like they're being pulled to one direction. And that's because it's affecting the cerebellum, there, our balance center, okay? If you attempted to have them walk a straight line, they wouldn't be able to. In the hospital, what we do is we do a testing called finger to nose. So if I stuck my finger out and said, touch my finger, touch your nose, they wouldn't even be able to touch my finger. They'd be totally overshooting because they may not have that balance is not there. E stands for eyes, a sudden change in vision, loss of vision, double vision, blurry vision. So this picture here is describing that. So this is your two eyes looking out. Maybe they lost vision in just this little peripheral spot where all they see is a black spot. Or maybe they lost vision on that total side. They can only see from one way over. So if they're looking at you, they may say, I can only see one side of your face or something like that. Typically, these patients, because they think, it's a sudden onset, they're not sure of stroke symptoms, they may go to the eye doctor before they come to the hospital. And the eye doctor's like, no, you need to get to the emergency room. So F stands for face, so facial drooping. You have someone smile, their face might be droopy and may not be able to make a full smile. They may also complain of some numbness in their face. A stands for arm, but it also means leg. So weakness in the arm, in the leg, in the arm and the leg. Typically, stroke symptoms happen on one side of the body. So this will be, they'll be able to function fine on one side, but the other side would be affected. This may also include numbness, so that pins and needles prickling of one side. S stands for speech. So a change in speech. It can be multiple things. They may not be able to speak at all. They may be able to speak, but it may be slurred. They may be able to say words, but they're coming out all gibberish. Like they may be trying to say "be fast stroke screen," but it comes out all gibberish and mixed up. I like to use the word in the medical profession. It's not really a medical word, but word salad. It's exactly that. All the words are there and they're being scrambled up, tossed like a salad. And that's kind of a good analogy. And this is where family members may define it as that onset of confusion, because all of a sudden they were normal, and then all of a sudden they're like talking just nonsense. T stands for two things: terrible headache. That might be the only pain associated with a stroke, and not all stroke patients have a headache. And T also stands for time to call 911 because it is a medical emergency. All right, any questions on that? The thing with time too, in calling 911, the importance of that, I know, especially the elderly community, they don't want to draw attention to themselves in the neighborhood, or, they don't want to pay for an ambulance service, but, it's not very recommended that you drive yourself to the emergency room, especially if you're having a stroke and have weakness. But also, nationally, it is known that patients that arrive to the ER via paramedics or emergency EMS receive quicker care, because the paramedics are starting to assess the patient. They are doing vital signs, they're doing blood sugar, and most importantly, they're notifying the hospital of a potential stroke patient. Then we can alert our internal stroke team that we have a patient coming in. And because the most important thing for these patients is to get them to CAT scan to review what is going on in their brain, it also includes the CAT scan team. They have to clear a table, be ready for that patient to come in. Our team also includes, nurses, doctors, technicians, our radiologist that's going to be reading those images, our pharmacy department that may be mixing medication for those patients, a neurologist that deals with, stroke patients, and neuro interventionists that we'll talk further about in just a moment. Okay, another patient here. So this patient, I'm actually gonna play a real EMS radio call for you first here.
We can't hear it. I think there's an option. I think there's an option when you're presenting to choose play the audio.
Okay.
Usually you have to unshare and then reshare with that option clicked.
Okay.
It's down at the bottom. There's like two little check boxes.
Is it an advanced sharing options? No?
Yeah, I think once you hit share, it'll present those options.
Oh, share computer sound.
Yes.
Yep.
Okay, let's try this again.
So it's positive for.
Okay, can you hear that? I'll just back it up.
All Saints, go ahead.
All Saints, receiving at 3, stroke alert, repeat, stroke alert. We're at your facility with a 65-year-old female patient to the hospital doctor's chief complaint this afternoon is a possible stroke. She is dizzy, so it's positive for balance on a BFAST stroke assessment. Patient at approximately last known well time was about 14-15 hours. She was wrestling with her daughter when she experienced a sudden extreme headache. Patient has also vomited with us. Patient states she does not feel good. She's extremely diaphoretic and dizzy at this time. Current vitals are...
All Saints, go ahead.
Yep. All right, so this patient, she had a medical history of high blood pressure, so that's hypertension. She had a heart attack before. She had high cholesterol levels. She's diabetic and obesity and smoking. So EMS reported multiple things. They called a stroke alert. So they alerted us that this is a potential stroke patient. And if you recognize the symptoms that they were reporting, so a sudden onset of an extreme headache, dizziness, loss of balance, and then because of the headache, that excessive vomiting and nausea, and she just didn't feel good. So they alerted our team. The stroke alert was paged early. The patient arrived. She went to CAT scan, and it showed an extensive SAH is subarachnoid hemorrhage, so a hemorrhagic stroke. She actually had a ruptured aneurysm of the anterior communicating artery, and that's this artery right here. So just a little description here. So this is the circle of Willis. This is the highest area of aneurysm development. And the reason being is that, so you have the posterior circulation, the back part of the brain, we got the vertebral arteries coming up here. And then this is the front part of the brain where you have the carotid arteries coming in. And then they all feed to this. They're all kind of connected. You know, our blood vessels are connected. And the aneurysms can develop in this area because there's a lot of blood flow through there, and there's multiple different angles and turns that this aneurysm can develop. And basically an aneurysm is described as like an outpouching of the blood vessel. EMS, you may have also heard them say that her last known well time was at 14:15. So the last known well time was the last time the person was normal without any stroke symptoms. 14:50 in medical profession, we use military time for our clock time. And basically that is so that we are not wondering if someone says 2 o'clock, is it 2 o'clock in the morning? Is it 2 o'clock in the evening? So 14:15 is actually 2:15 in the afternoon. So this is what was found when she went for neuro intervention. So this is like a 3D image of the blood vessels in the circle of Willis, and here is that aneurysm. So you can see it's definitely an outpouching of the blood vessel. It looks totally different than the other blood vessels. This is after they inject with dye to look at that aneurysm further. It's right here. You can see the outpouching. And then she had a procedure called endovascular coiling, where basically they're releasing coils into that aneurysm so that it blocks the blood flow from going in there. Basically, it'll, you know, it's a bunch of little coils that go in all at once so that the blood flow can continue on in her brain instead of going in that aneurysm. So we were talking about posterior circulation and posterior strokes. So about 20 to 25% of strokes involve the posterior part of the brain or the back part of the brain. So it's very interesting that the posterior circulation is the only vascular area or region in the body where you have 2 arteries, the vertebral arteries here in the blue, that come together and unite and form a large artery here called the basilar artery. The basilar artery actually feeds our brainstem. And what is the use of our brainstem? It controls everything throughout our body as far as our breathing, our heart rate, our respirations, all of that is controlled by our brainstem. And then the basilar artery breaks off then into the posterior cerebral artery, and this is where it connects to that circle of Willis. So these patients can also have a few other extra signs and symptoms of stroke. So we call that the 5 Ds of posterior circulation. So basically 5 extra stroke symptoms that all start with D. So dizziness, 47 to 56% of cases, they'll have that dizziness. And we talked about that earlier, and that's affecting our balance where, that sudden onset of dizziness where you can't even walk straight. Diplopia or double vision. Dysarthria is that difficult or unclear speech, so they're slurring their words. Dysphagia is a new one, and that's not in the BFAST symptoms, but difficulty swallowing. So a person having a stroke may not be able to swallow even their own saliva or even swallow water properly. And then dystaxia, which is just a D added to ataxia, so that loss of balance or coordination. And again, stroke symptoms will be sudden in onset. Some dizziness, and then that double vision. Extra dizziness. Okay, what puts us at risk for having a stroke? There's multiple things that can be risk factors for stroke. So atrial fib flutter. On the right-hand side of the screen, I have an example of what that would be. Atrial fib flutter is an irregular heart rhythm. Basically, the top chambers of the heart just kind of quiver and don't eject all the blood out. And then clots can start to develop in those chambers, and then a clot can break off and travel to our brain. So this top portion is what a normal heart rhythm would look like, and the bottom portion is atrial fib. So it's irregular, it may be fast at times, it may be normal rate, and a person may not realize that they're in that heart rhythm, but it actually puts a person 5 times more at risk for having a stroke. And about 75,000 cases of stroke per year in the US are caused by persistent or intermittent atrial fibrillation. So other risk factors: obesity, high blood pressure, high cholesterol, diabetes, heart disease, race. African Americans are 3 of 4 African Americans, and that goes back to the high blood pressure, have hypertension by the age of 55. And the Wisconsin Department of Health put out information saying that 17% of Wisconsin adults diagnosed with high blood pressure are under the age of 45. And that's one of those reasons why strokes are starting to affect younger people. And that information is only those patients that actually go and see the doctor, yearly and have their blood pressure taken and that type of thing. High blood pressure can be a very silent killer. You don't realize that your blood pressure is high unless you're having it monitored. Okay, so race. African Americans are twice as likely to have a stroke than other races, and Hispanics have strokes at younger ages than whites. Age is not, there's no age requirement for strokes. As I have mentioned, we have had strokes in our community, patients as young as 25. We've had multiple 30-year-olds having stroke. Other risk factors: smoking, vaping, secondhand smoke, excessive alcohol or drug use, lack of exercise, a previous stroke or TIA. A TIA is like what they call a mini stroke, meaning you've had stroke symptoms, but they went away and the MRI did not show any damage. Medication noncompliance. A lot of patients stop taking their medications because they may feel okay, but like I mentioned, high blood pressure is a silent killer because you don't realize that your blood pressure is elevated. And how do we decrease our stroke risk then? So we get up and be active, right? We put those cell phones down, we put those video games down, we get out and walk and relieve some stress by doing some yoga or going to the lake. Keep our weight at a good weight. We eat items in the nutrition pyramid and, choose colorful fruits and vegetables, good healthy proteins like fish, chicken, some grains, some healthy spices and oils. We go to the doctor and have them examine us. We have our blood pressure checked. We take medication if we need medication as it's prescribed. No smoking, no vaping, and monster drinks. We got to be careful about any of those energy drinks or pre-workout. My son actually, as a 20-year-old in college, developed atrial fib, that irregular heart rhythm. And they felt that it was probably due to him using pre-workout before he lifted. There's a lot of caffeine in those and they're not regulated by the FDA. So you really don't know what might be in those. Any questions?
I have a question. I have a good friend who had a stroke last year, and she's in her like low 40s. And the doctor mentioned that stress was a major contributing factor. So I was just curious how stress has that effect on the brain and everything you've been talking about.
Stress really can be impactful to any disease process. It increases our inflammation in our body. It can raise our blood pressure. It could potentially cause irregular heart rhythms. So it really is a regulatory portion of our being. Not only that, but COVID-19 actually has been known to cause clots in strokes in younger patients, and even patients that aren't that are asymptomatic or without symptoms of a stroke. They can develop that. There's a clotting cascade that occurs during COVID that can cause those clots to form. And the thing with the younger people having strokes too is, go back to that term cryptogenic stroke or stroke of unknown cause. We really try to look for what might be causing that. There's things such as placing little loop recorders, which I have a picture of it here. It's a little, I don't know if you can see that. It's a little device, I'll take it out of the bag here, that's actually implanted just under the skin in the chest, and it actually monitors their heart rhythm internally, and the battery life of the new one is 4 years, because that irregular heart rhythm, that atrial fib, can be so intermittent that a person doesn't realize they're in it, or it can be sporadic, like they may not have it. They've found in their studies that some patients aren't identified that they're in atrial fib till that 3rd or 4th year. My son didn't realize he was in that AFib until his heart function got so bad, and he was having shortness of breath and palpitations. It improved, thank goodness, because he got out of the rhythm and stopped using pre-workout, so that was helpful too.
I actually had a question about I think race was a factor. How does that affect it? Like, why are Black people more common to have a stroke?
I think they're also more common in those races for high blood pressure, potentially other comorbidities, family history, the ability and the ethical, going to the doctor and diet, those things all are impactful in that. But hopefully, with the Coverdell Stroke Program in Wisconsin and working very closely with the Wisconsin Department of Health, we can improve that classification of ethnicity as being an impactful portion for strokes. Good question, though.
I had a question too about recovery, because it seems like I know a variety of people who've had strokes, and they all had very different means of their recovery process and what abilities they were able to regain. Is there any rhyme or reason as to why that is?
We're going to talk more about treatment just shortly here. A lot of it has to do with how big of an area of the brain is being affected. If it's a smaller blood vessel, therapy, intensive therapy in the first couple months after a stroke is what's really going to improve stroke deficits. So it's very interesting. Our bodies are very unique beings in that repetitive therapy, yes, it's exercising, but it's also exercising the brain, and they can actually develop other areas of the brain to do what that area can't do anymore. But it's with that repetitiveness, and especially in that first 3 months after a stroke. And sometimes, unfortunately, patients don't come in right away, and that can decrease the ability to gain some of that back. When a person presents quicker, there's other treatments that can be had, and also other medication and monitoring that occur immediately with that patient to improve things. Great questions. I like it. Okay, so I'm just going to describe a couple terms. So with our stroke patients, anytime we have a patient come in that has stroke symptoms, we do 3 different CAT scans. So the one initially that I talked about was the CAT scan, non-contrast, just looking at the bones of the head and also the brain tissue. Then we have one called CTA, which is a CT angiogram. The person's injected with contrast, and it's looking at the blood vessels in the neck and the brain, looking for any narrowings, or it could even detect a clot. And then CTP, or CT perfusion, and I'll have a picture of that shortly here, is actually looking at that ischemic stroke patient, and we can actually pick up areas of brain that already have an area of dead tissue, and then an area of salvageable tissue, which we call the penumbra. It's kind of a cool name. And I'll talk more about that shortly. With that CTA and the CT perfusion, we actually can pick up LVOs, which are large vessel occlusions. So the larger blood vessel is blocked with the blood clot. And those patients may qualify for what we call mechanical thrombectomy, where actually a neuro interventionalist goes in and actually pulls the clot out with this little device here. And I'll have a better picture of that shortly too. But this is actually a stent retriever that goes in and pulls the clot out. And that red there is actually some of the clot that was pulled out of the brain blood vessel. Then if patients arrive within a short time, we can give a thrombolytic, which is a clot busting medicine. So basically it's a medication that is injected through the IV, that the purpose is to break up that clot. Patients can only receive that up to 4.5 hours after the start of stroke symptoms, or after the last time they were seen without any symptoms. So that is very time sensitive. And one other important thing looking back here is that that's why it's so important to do that CAT scan, because we want to rule out that they have any bleeding in their brain, because obviously they wouldn't qualify for the clot busting medicine if there's blood there already, because that would be detrimental. Mechanical thrombectomy, or pulling the clot, can only be performed at certain hospitals because you need a neuro interventionalist and a whole team that cares for those patients. Unfortunately, in southeastern Wisconsin here, Kenosha, Racine, we do not have a hospital that has that capability. So those hospitals are in Milwaukee. Our imaging that we use a rapid software technology, and actually that rapid software technology gets pushed to our neurointerventionalist at Ascension Columbia St. Mary's, and he receives those alerts on his Apple Watch, on his iPhone, saying, hey, there's a patient at All Saints that maybe has a large vessel occlusion. Look at these images. And he'll be able to visualize those right away on his phone. So it really helps expedite getting those patients where they need to go. All right, that clot buster. Here's where our math is going to come into play. So the clot buster that we can give is called Alteplase or Activase, but basically it's a thrombolytic. So it's going to bust up that clot. So the dose of that is 0.9 milligrams per kilogram with a maximum dose of 90 milligrams. So in healthcare, kilograms is a metric of weight measurement typically used in European countries, but it's also used in healthcare. So what we would do is, let me just, so we take our pounds. Here's our math equation. We got X is our pounds divided by 2.2046, but you can just say 0.22 equals how many kilograms we have. So say we have a 200-pound patient. How many kilograms would that patient be? So 200 divided by 2.2 would be 90.9. So then we take our 0.9 milligrams of our medication by the weight, multiply it by the weight, so 90.9 kilograms, and our dose would be 81.8 milligrams. So of that 81.8 milligrams, we give 10% of the dose over a minute, and that's just through an injection through the IV, a little bolus, and then the remainder runs over an hour. So the remainder of the clot-busting medicine runs over the next hour. So there is other, science is always looking for better ways to do things. And there's one other medication that they're looking at for these stroke patients. And basically it's just a medication, it's weight-based again, but it's only given in a bolus dosing. So American Stroke, American Heart Association do all of the scientific studies on these patients, and then they make their recommendations. And that's what the hospitals follow for our stroke care, because we all want to be following what science is showing us, right? Okay, so I'm going to show you this video. Hopefully this turns out okay here with our technology. So this is basically going to show how the clot-busting medicine works. So you have that plaque that ruptures in the artery, and then it starts the coagulation cascade. So here we go.
Ruptures and
change the setting here.
Activates the coagulation cascade. Platelets and red blood cells aggregate at the site of vessel injury, further narrowing the artery. This impedes blood flow and causes turbulence in the artery. As the thrombus grows, it continues to narrow the vessel, leading to partial or even complete occlusion. A cerebral embolism occurs when a piece of thrombus breaks off in a vessel in the body and travels to and lodges in a vessel in the brain. This can cause ischemia and can progress to infarction, an acute ischemic stroke. Beyond the infarction lies still viable tissue called the penumbra. Brain cells within the penumbra are potentially salvageable if blood flow and vital oxygen are promptly restored. The penumbra is the focus of thrombolytic treatment. Now let's look at the
Okay, sorry, we missed that portion of it. So basically then that the clot-busting medicine is working on that clot. It's gonna break up the fibrin so that blood flow can be reestablished and get to that penumbra, that area that we're trying to save. So I'll show you another picture here.
Ruptures and
here we go. Okay, so this is another depiction. So when a stroke, ischemic stroke starts to happen, you have this black area here that's already dead tissue. That's the core infarction. This is the blue, and the green is that penumbra, that area that's going to go on to die unless we treat that patient with something, okay? And as time goes on, that dead tissue starts to grow, right? So at 2 hours, we're already more than doubled the size of the stroke. And then at 12 hours, that area is all dead already. Now, this is how it looks on that CT perfusion that I was talking about. So when a patient first comes in, that's one of those scans that we do that goes to that rapid technology. So you can see here that little pink purplish, that's showing the core infarction or the area that's already dead. Now this whole green area will go on to die in addition to the core infarction unless we treat that patient. With this rapid technology, it actually flags the imaging that says that this patient may benefit from thrombectomy or pulling that clot out. So basically you're taking this whole volume minus the core infarction, and this is the area, 57 milliliters is what we can potentially save of brain tissue for that patient. All right, now I'm going to show you how the clot is pulled from the large vessel occlusion. Now there is no sound for this, so it's just going to show the actual video. I have to get to the YouTube presentation, sorry. There we go. So this, they're injecting the dye to look at the blood vessel, and this is just an animated portion. They put that stent retriever all the way through the clot. It's just kind of a guide wire, and now they're going to deploy that stent that's going to pull that clot out. They have little markings on the stent so they know where to start and stop. Now they're going to open it up, and it's kind of like the inside of a pen, you know, that little coil in there. And it's basically attaching to that clot. And then they pull it right out. And now they're checking that the blood flow is going through. All right. Let's see here. Are you seeing my pull the clot screen now? Or the, okay. And now you should see the other imaging. Okay, so this is what that's showing then. So on the left-hand side, the before picture, they're injecting the dye to look at the blood vessels in the brain. And you can actually see here that you can slightly see the clot sitting there. It's more white, right? And there's just this little trickle of blood getting through there. And these were the clots that were pulled out. And now all of this blood flow is restored back to that portion of the brain. So look at the difference between here and here. In the setting, this is another kind of cool thing. When there's a large blood vessel that's blocked, so an LVO, large vessel occlusion, so there's no blood flow, so no blood or oxygen can get to this portion of the brain and the cells start to die, right? Well, our bodies actually are made that we have what's called collateral circulation. So it's little spider web of blood vessels that sits on the top of our brain that can be recruited to bring blood flow to that area to hopefully bring that extra blood flow there so that area doesn't die, which it's really cool. We don't know though, you know, it's unpredictable as to how many patients have good collateral circulation and how many don't. So they may deteriorate more quickly than others. There's really no science behind that as to how we can, which patients will have the best collateral circulation. But when someone's having a stroke, their blood pressure is very, very high, like 100s, 200s over 100s or 120s. But that's another body defense mechanism. It wants to bring that extra blood flow. So raising the blood pressure is going to bring that extra blood flow to the brain. So one stroke, we talk about how time sensitive it is. As I mentioned earlier, nearly 800,000 of strokes occur each year. Someone suffers a stroke every 40 seconds, and stroke is a leading cause of preventable disability. About 80% of strokes can be prevented by controlling those risk factors. And another interesting fact for those science gurus out there, every second there's 32,000 neurons or brain cells that die, which ends up being about 1.9 million in a minute. And then in the same minute, your brain loses 14 billion synapses. And that's that, you know, vital intersection between the neurons. When a clot blocks an artery at the start of a stroke, the damage can be very swift. And that's why we have to all be alert and know what stroke symptoms are, calling 911 and getting that patient the treatment they need. All right, who can name some stroke symptoms? I'm gonna test your knowledge. Remember, that was my #1 goal, that we take away from this stroke symptoms.
Jalen typed in the chat balance.
Yes, very good. Number 1, balance. So that dizziness, can't walk straight.
Michaela, you got one?
All right, what about that change in vision, that double vision, blurry vision, loss of vision? Facial drooping, so you have someone smile and you see how his face is drooping on the one side. Arm weakness, so you see you lift both arms up and she can't lift one as far, or she might not be able to lift it at all. That numbness in the face, in the arm, in the leg, so pins and needle kind of feeling. That leg weakness, so she can lift one leg real good, but the other one she can't lift at all. Speech, so jumbled up words, can't speak at all. And many times these patients know what they want to say, but they just can't express it properly. Terrible headache, right? Sudden onset of the most horrific headache ever. And what do? Call 911, right? Stroke is a medical emergency. I appreciate you listening. Do you have any other questions? Really thank you for having me, especially in light of Stroke Awareness Month. You may be seeing, look at your local Quick Trip when you go there. BFAST Bella is on the inside of the Quick Trip screens, so not at the pump, but inside they have some screens. They did that last year also. It's going to be also on the buses in Milwaukee, on radio ads. I know Ascension has radio ads out there for stroke awareness and the importance of getting to the emergency room and recognizing those stroke symptoms. So you'll be hearing a lot of that this month.
Well, thank you. That was extremely interesting, and we'll make sure to share it with our classes.
All right, awesome. Thank you so much. Yeah, and let me know if you need anything. If anyone comes up with any questions, just